The goal of this module is to learn how to perform a focused physical examination on a stable preterm infant, in this case a 700-gram, 25-week gestation infant who is a few days old. Examination of the preterm infant can be challenging as the infant may be critically ill, unstable, or intolerant to a comprehensive physical examination. In such cases, an opportunistic focused physical examination may be required. Ideally, the physical exam should include inspection, palpation, percussion, and auscultation, but this order may need to be modified depending on the diagnosis and stability of your preterm patient. Remember to plot the infant's weight, length, and head circumference on a growth chart to assess if your infant is appropriate for gestational age, small for gestational age, or large for gestational age. On inspection, note general observations about the patient, including whether the infant looks sick, cyanosed, anemic, jaundiced, or appears to be appropriate for gestational age. This preterm infant is lying comfortably in his isolette in the supine position. Electrodes for monitoring his heart rate are on his chest, and a pulse oximeter is attached to his left foot. There is a temperature probe on his right flank. He has an orogastric tube for enteral feeds. His respiratory effort is being supported by bubble CPAP. Parenteral nutrition is running through an umbilical venous catheter secured to his abdomen by tape. When examining your patient, make sure you also assess the infant for any facial dysmorphisms. This is not always easy, especially if the infant is requiring respiratory support. Note skin lesions such as birthmarks, rashes, or neurocutaneous lesions, and any other obvious abnormalities. Also, don't forget to inspect the umbilicus. Next, auscultate the heart after you have first noted the position of the apical impulse, which can quite often be easily seen in the preterm infant. Remember to specifically listen for the valve closing sounds S1 and S2, extra sounds S3 and S4, murmurs, arrhythmias, clicks, and rubs. This is made easier if respiratory support is briefly interrupted as tolerated. And palpate for precordial heaves or thrills. Remember to assess capillary refill and check your femoral pulses for symmetry and brachiofemoral delay. After assessing for signs of respiratory distress, such as nasal flaring or retractions, check the nares and nasal septum for any breakdown, especially if prongs are in place. Check the oropharynx for any clefts. Auscultate the lung fields, paying particular attention to any asymmetry in air entry and breath sounds, and any added sounds such as crackles or rails. In this infant, you can see intercostal and subcostal retractions despite being on bubble CPAP. Examine the abdomen, assessing for distension, visible peristalsis, or bowel loops, any tenderness or guarding, hepatomegaly, splenomegaly, hydronephrosis, masses, and bowel sounds. Make sure the anus is patent. In addition, don't forget to assess for inguinal hernias and make sure they are reducible and not strangulated. Check for diaper dermatitis and any anal fissures. Also inspect the contents of the diaper. In boys, check that the testes are distended. The neurological examination may be limited if the infant is on sedation or muscle relaxants. Where possible, assess tone, movements, and reflexes for symmetry. Also check primitive reflexes such as the Moro reflex. Remember to check the fontanelles to see if they are open, bulging, or depressed, and assess for moulding of sutures or any evidence of caput, cephalohematoma, or subgaleal hemorrhage. Check for any signs suggestive of spina bifida occulta such as hair tufts or sacral dimples. Check the palm and digits and inspect for foot deformities such as clubfoot. Once your examination is completed, remember to make sure your infant is comfortable and stable before moving on to your next task. That concludes the module on physical examination of the 25-week gestation preterm infant.